So it is of we were discussing coronary heart disease, and we knew that atherosclerosis will lead whether vulnerable plaques or stable plaques with risk factors, and it can lead to stable angina. So our specific learning objective for this session is definition of chronic stable angina. We defined it previously, and we went through all these three criteria for typical angina. Now we will focus on the SLO of clinical signs and symptoms and stable angina. Basically, there is a fixed stenosis with a stable fibrous block. There is demand-led ischemia. It is related to effort. It is predictable. Symptoms are over long term, and symptoms occur on minimal exertion. Sometimes exercise testing and CT coronary angiogram are the ways to investigate this issue. So what are the clinical symptoms and signs? Effort-related chest pain is hallmark. Reproducibility, predictability, and clear relationship to physical exertion and occasionally emotional stress. Key features in symptoms are duration of symptoms. Recent onset angina indicates higher risk than long-term stable symptoms. Physical examination will often be normal in stable angina, and history may and examination may reveal risk factors like xanthomas, which indicate hyperlipidemia. LV dysfunction, like regional wall motion abnormality, for example, dyskinetic apex beat, Gallop rhythm, indicate that patient is having higher risk. There may be other arterial manifestations like carotid breach, peripheral vascular disease, etc. Unrelated conditions may exacerbate angina, like anemia, thyroid disorders, and any cause of sinus tachycardia could also be the cause, precipitating angina. Activities that commonly precipitate angina are physical exertion, cold exposure, uncommon lying flat, decubitus angina, heavy meals, intense emotions, and in nocturnal angina, patients may have vivid dreams. Whenever you have a patient of stable angina, you will risk stratify to higher risk versus lower risk. Higher risk patients are post MI, post infarction, having angina, poor effort tolerance, ischemia at a low workload or slight workload, left main or triple vessel coronary artery disease on angiography, poor LV function. These are high risk patients. Low risk patients have predictable exertional angina, good effort tolerance, ischemia only at high workload, single vessel or two vessel coronary artery disease, and good LV function. But these are not rigid categories, and a patient may fall in between these categories. Other stress tests that are used for evaluating are myocardial perfusion scanning and stress echo and coronary angiography. Myocardial perfusion scanning evaluates equivocal or uninterpretable exercise tolerance test. 99 technetium tetrophosphine uptake in viable myocardium. Reversible defects indicate ischemia. Stress echo is alternative to perfusion scanning, identifies ischemic segments and infarction. Coronary angiography provides anatomical information about coronary artery disease, and it is basically a pre-step to assign patient to the bypass grafting or angioplasty. It is indicated for diagnostic uncertainty in atypical chest pain sometimes when the diagnosis is unclear. We already went through these categories. In next session, we will go for lab findings and imaging techniques with management protocol for stable angina.